This is the case of VSD with air, and also this case has PDA. Today I will discuss how to make difference between restrictive and non-restrictive VSD. Non-restrictive VSD, that means the bigger size, that means the patient will have more symptom. The severe symptom and more frequent symptom. In case of children, more frequent pneumonia and severe pneumonia. So more frequent and at the same more severe. If two things are present, in that means most likely VSD is non-restrictive in nature. Second thing, if the pneumonia is less severe or mild variety and less frequent, or patient does not have any pneumonia like symptoms, in that case the VSD is restrictive in nature, that means less in size. In this case you see this is VSD just below the aorta. There here aortic resorption jet is also seen because of damage to aortic valve. Why damage happens? Because the VSD has got restrictive VSD. The velocity of blood is very high in case of restrictive VSD, and that creates negative pressure to the valve, and that pushes the valve and finally damages the valve. So ultimately, if valve damage has started, then VSD should be closed early so that more damage to valve does not happen and valve replacement is not required in the later time. Again, regarding the size of VSD, if you compare the size of VSD with that of the size of aortic annulus, if VSD is less than 25% of aortic annulus, that means VSD is of a small size, restrictive VSD, and VSD is very much likely to close on itself. A spontaneous closure is likely finding if VSD size is less than 25% of aortic annulus size. So you have to compare the size of VSD with size of aortic annulus. In comparison, if it is less than 25%, then VSD is quite likely to close. VSD is most likely restrictive in nature. If VSD is more than 50% of that of aortic annulus, size of aortic annulus, in that case the VSD is non-restrictive. VSD is unlikely to close spontaneously. If VSD is less than 1/3 of that of aortic annulus, that VSD is also likely to get closed spontaneously, but less than that of VSD of those category which falls within 25% of that of size of aortic annulus. So finally, think if VSD is smaller in size, chance of closure is more. So clinically what you see, if more symptomatic child, VSD is restrictive. If VSD is very small compared to size of aortic annulus, then VSD restrictive. If LE or LV is not that much enlarged, very mildly enlarged or prominent in size, then VSD restrictive. LE LV severely enlarged and right heart also got some pulmonary artery hypertension, LE and LV failing, left ventricular failure, that means VSD is non-restrictive in nature. Because of VSD, LV is failing, that means VSD is of big size. So ultimately, clinically what you see, less symptom, restrictive, more symptom, non-restrictive. LE, LV normal in size, restrictive. The severely dilated and failing, non-restrictive. If you just compare the size of VSD with size of aortic annulus, if VSD is less than 25% restrictive, more than 50% non-restrictive. So by doing all these things, you can say whether the VSD is restrictive or non-restrictive. And one thing is gradient wise, if velocity of VSD jet is more than 4 meters per second, that means it is restrictive. In newborn children, even velocity is more than 3 meters per second is in the category of restrictive, because right side has got some pressure and that is opposing the flow from the left side. So the peak gradient, even restrictive VSD has got little bit less peak gradient or less velocity compared to what it should be. So in case of newborn, if velocity across VSD is more than 3 meters per second, that means it is restrictive. But in case of more than 6 months old, more than 6 weeks old child, we have to see more than 4 meters per second, then we call it restrictive VSD. But in case of, if you see right sided systolic pressure to be raised, RBSP to be is high, in that case you have to compare the size of VSD with that of size of aortic annulus. If it is less than 25, it is restrictive. So VSD restrictive, I have already said, clinically symptomatic, that is symptom. Second thing is if it's echocardiography, LALV size failure is there or not. Second is P gradient. Third is size of VSD versus size of aortic annulus. So by all these things you can say whether the VSD is restrictive or non-restrictive. The next slide I am moving. You see the gradient in this case is 4.82 millimeter of mercury and velocity is 4.5 meter per second. So this VSD is restrictive. You see this case has got PDA also, very small PDA, restrictive PDA. I have already told you in one video that if the size of LEA is more than 2 times of that of aorta, that means LELV enlarged. If that is with PDA, then PDA is non-restrictive. PDA is large or PDA is non-restrictive, because LEA has and LELV has enlarged and it has become more than 2 times of that of aorta. So in case of large PDA, if size of LEA is LELV enlarged. Gradient, but if you see the gradient, if gradient more than peak gradient is more than 64 or velocity more than 4 meter per second, that means PDA is restrictive nature. This is PDA. Again, this is the VSD outlet infracrystal VSD. VSD is away from primary valve and away from tricuspid valve, almost in between of these two valves. So infracrystal, outlet infracrystal VSD. VSD has caused AR, so VSD has started to damage aortic valve. Child is 5 years old, so this VSD needs to be closed. Here the size of VSD is only 1.1 millimeter. If you measure the size of aorta, that is 11 millimeter. So almost 10% of that of aorta. So VSD is likely to close, but VSD is also damaging aortic valve, causing AR. So in this case, even VSD is likely to close. VSD needs to be closed early so that no further damage happens to aortic valve. Again, you see the VSD and AR. LELV prominent size or higher side, you can say LELV mildly enlarged, if not severely enlarged. See the PDA, size of PDA, very small, restrictive. The gradient of P gradient of PDA is 82 millimeter mercury and velocity is 4.5 meter per second. So restrictive PDA. Even the diastolic gradient, the minimum gradient you see, minimum gradient is also very high. That means the patient does not have any pulmonary artery hypertension. If there is pulmonary artery hypertension, then P gradient and mean point both will decrease. So this case does not have any pulmonary artery hypertension. At the same time, PDA is restrictive in nature. Still PDA, we all know that PDA never closes on itself if does not close within 15 days or preferably within 3 days, but mostly if does not close by 15 days, that means PDA will not close spontaneously, that PDA needs closure. PDA is closed in the best way, either by device or by surgery. That is the point to learn from this video, because some of my viewers asked me how to differentiate between restrictive and non-restrictive VSD, between non-restrictive PDA. So in case of PDA, if you just consider sizes less than 2 or 3 millimeter, that means it's a small, but the gradient is more than 4, it is always restrictive. In case of VSD, just in size, compare the size of VSD with that of aortic annulus. Less than 25% restrictive, likely to close. Thank you.